Good afternoon or morning to everybody out there. Thank you very much for joining me here at Healthmonics as we present the 2024 proposed rule, Understanding the Impact on MIPS. Today, I am joined by none other than Lauren Patrick. Hi, Lauren.
Hi, Mike.
We'll be going over the proposed rule that was released last Thursday and our thoughts around what some of it means, as well as the steps you need to take now to prepare yourself for next year. A couple housekeeping notes. If you look onto your GoToWebinar widget, you'll see that I have included the handouts for today's presentation in the bottom right-hand corner, as well as an opportunity to ask us questions. This is a very detailed and long webinar today, so if we don't get to your questions, Lauren and I will take a look at them after the call and hopefully be able to get you an answer by early next week. So some of the things we're going to review today: one, what is the impact of the proposed rule? MIPS value pathways took a very big turn in 2023 being introduced, but in 2024, they added a number of different steps and a number of different measures and so forth to really change what MIPS value pathways look like. And then how do you set yourself up for success? So CMS had a couple of objectives for 2024 that they laid out in the preliminary rule. The first one is to create a more equitable healthcare system that results in better access care, quality and affordability and innovation. Further advance CMS overall value-based care strategy of growth, alignment, and equity. Transitioning away from COVID-19 with the end of the PHE, so 2024 will be the end of that, and getting the quality payment program back on track. Moving people from traditional MIPS reporters towards the MVPs, as well as implementation of the universal foundation of impactful measures across all CMS quality and value-based programs. I think you'll see from here a lot of the topics and a lot of things that we talk about here on the in the proposed rule have to do with creating something in the background. Someone is saying that I have music on in the background. I have no sound. My dog just barked though, so I apologize if the sound is coming across weird. And then supporting the introduction of digital measurement. So let's get right into it. For 2024 MIPS reporting, everything's remaining the same as far as the categories, with 30% from quality and costs, and then PI at 25% and improvement activities at 15%. Still the same thing for eligibility as well: 90,000 plus in Medicare Part B charges, 200 plus Medicare Part B patients, and 200 plus covered professional services. To be automatically needed to report those, you need to have all three of those categories met. You can opt in to report if you have at least one of those three met. If not, there still is the ability to voluntarily report in 2024. Couple high-level overview of some of the proposed changes. Performance threshold was raised again. There are 5 new cost measures. The removal of commonly used quality measures, I think, is going to be pretty important and a part that you want to make sure you get. Health equity impact, changes to promoting interoperability, 5 new MVP options, including more specialties, giving more people an opportunity to take that next step into MVPs, as well as changes to the current existing 12 MVPs based on feedback from clinicians. All right, let's get this one out right away. Performance threshold has been raised, or will be raised. CMS is proposing an increase to the performance threshold from 75 points to 82 points. That is, moving up, as you can see, all the way from the beginning of the program back at 3 points up until this year, where you saw 75 the last 2 years, and moving up to 82. How does that impact you? There will be no easy out for MIPS. That kind of disappeared in 2022. And there's really no tricks. I know in the past, if you've been part of my webinars, I spent a lot of time teaching tips and tricks of how to get to where you need to go. There'll be tips, but there's not many tricks to being able to get up to that 82 points. And more providers are going to be penalized than any other year, and we'll go into that in just a minute. CMS concern for high performers is something that came up a couple times within the proposed rule. They share that participants are choosing the same measures every year, knowing that they will perform well. So they pick the same measures, do the same stuff, knowing that they would get a high score for those measures. CMS is considering modifying the scoring policies to encourage participants to improve year over year. It could include more rigorous performance standards, so increasing those benchmarks. I'm not totally sure how they can do that on some of these measures, as the benchmarks are quite high on many of the measures that have been around a while. Emphasizing year-to-year improvement, so paying bonus points or bonus opportunities for improving on your numbers, and then requiring clinicians to report on different measures if they have demonstrated high performance consistently. So they didn't give an example, but I would assume that it is, 1 or 2 or 3 more years of reporting the same measure and getting almost a perfect score. They're not going to allow you to report that measure in the future. Once again, just for everybody's knowledge, this is all proposed. Nothing is written down in pen, and it is not, it won't be finalized for a little bit of time. All right, on the next slide, I'm going to push it over to Lauren, and she's going to discuss a little bit about the payment adjustments.
Sure, Mike. So this is a table that CMS put forth in the proposed rule. As he said, what they are proposing doing is taking the average of three prior years median scores, and that came up with an 82 for a threshold. So when they look at that threshold, then what they do is they look at, well, what would happen if they stayed at 75 versus moving up to 82, and they wanted to get a feel for that. So what we're showing here is that due to the higher threshold, there's going to be more folks having a negative adjustment and fewer positives. There is really if you look at the graph of scores, you see that the scores really do cluster in the 75 to 85 points. And so any little movement they make there really shifts the number of providers getting a positive versus negative. The good news is that even if you're moving from positive to negative, if you're kind of clustered around there, you could be moving from a positive of 0.01% to a negative of 0.01%. So they really do scale it. This gives you a sense of what the impact's going to be. We see that for smaller practices, they tend to do more, they tend to have lower scores, and so more of those are going to see a negative impact. It's interesting because in the past they've done a lot with small practice bonuses and so forth, and as we move forward, they're tending to reduce those more and more, and this is the consequence of that. Next slide. So here what we see, oh goodness gracious. Here what we see is we see the maximum positive payment adjustment based on the fact that they are moving to an 82 in their proposed rule, that it will go from a 4.6 to an 8.82. And I think this year, I know that in the past we've seen a lot of hypothetical increases in the maximum score. I think now that the PHE is over and the impact of COVID is really lessened significantly, we are going to see more significant positive payment adjustments possible, and makes it perhaps more worth your while to work on achieving. I know that it can be a burden to get through all of the reporting requirements, but there is, I think, more of an incentive going forward. And this sort of shows you the impact of moving from the 75 points to the 82 points. And that's all I got on that, Mike.
Sure. Thank you, Lauren. Passing it back to me to start going over some of the changes in quality. We're going to work through each of the 4 categories and then get into, or as well in here, we'll include the APP and changes for ACOs, as well as going a little into more detail about the MVPs. So first off, when it comes to data completion threshold, they're planning to move it up, not now, but this year to 75% in 2024 and continue that through 2027 program year where they'll up it to 80%. The goal is they would like to get that up to 100%, believing that clinicians should be reporting on all patients. The thresholds were intended to reduce burden and accommodate operational issues that may arise during data collection during the initial years. And they're basically stating here and talked about in the proposed rule that 50% in the beginning was where they were at to reduce that, and that the expectation is that people should be well in the way of being able to do this, considering this is moving into, I believe, 1, 2, 3, 4, year 7 in 2024. So CMS prohibits also cherry picking the best 75% of your data. They expect you to be able to report on as close to 100% and not choose just your best 75%. So there are 14 new measures that are proposed for 2024. I'm not going to go into detail on all of them, but as you can see here, there are a number of high priority and outcome measures, which is good options for you when scoring, because you still have to select one of those as one of your 6 measures. They are mostly all available as CQMs, except for the first one you see up at the top is available as an ECQM. So you need a certified 2015 cert EHR to be able to report those. The one thing I do want to call out with these measures is that still 7 points for new measures in 2024, very similar to 2023. And for second year measures, 5 points is the minimum that you will get. So they're a good resource to maybe report 7th or 8th or even 9th measure during the year and know that you'll at least get the minimum points of 7. That you'll see. I did want to call out one of the new quality measures here is the connection to community service provider. It is a continuation from another measure that has the SDOH and looking at health-related social needs. And this one takes it a step further. Basically, it includes all patients 18 and over with over 100 eligible encounter types. So it's basically every encounter type across the board. There are no exclusions and no exemptions. Patients who are screened screen positive for at least one of the 5 will need to be in the numerator. So to be in the numerator, patients who had contact with a community service provider for at least one of their health-related social needs within 60 days after screening. Another new quality measure I want to bring attention to. This is a very interesting measure as it has 7 different strata that CMS is looking to have. So as you can tell, or by just looking at this, very similar to measures in the past. If you remember the numbers, you're looking at 110, 111, 112, 113, 138, 226. 236. These are all very normal measures that you've been reporting on for years. They are going to combine them all into one gigantic process measure. So percentage of patients who received age and sex appropriate preventative screenings and wellness services. Each of the denominators are different, but you'll be reporting on it very similar to what you were doing before, but now it only counts as one measure. Proposed measures for removal. So I guess this is the scary part, because to be honest with you, many of these measures are very, very popular in reporting and have been popular since the program started and even back to the PQRS days. They are planning to completely eliminate 110 and 111. They were taken out last year. but they're going to remove them from MVPs moving forward as well. Other measures like 112, 113, 128, these are your cancer screenings as well as your BMI screening and follow-up. Those are all very popular measures that they are planning to remove. They are, measure 138, melanoma coordination care, was in the 2023 preliminary proposed rule, and they did not remove it last year, but my guess is that it would be gone this year. Another measure that they're looking to get rid of is 402, and that's the tobacco use and help with quitting among adolescents. It's a very popular measure as well. ACO performance pathway, I'm going to pass it back to Lauren, and she can go over that.
Sure, Mike. So CMS is introducing a new reporting collection called the Medicare CQM. It is just for participants in the ACO MSSP program. What it is it's a mechanism where ACOs can report quality measures just for the patients that are beneficiaries in that MSSP program. So it's sort of a consideration that CMS has made after listening to the concerns of MSSP participants, because the burden to report all patients across all participants in an ACO is significant. So it is available only for ACOs. It serves as a transition. Where CMS really wants everyone to go is to the unified reporting mechanism and to digital measures. So CMS is viewing this really as a transition, at least for the next couple years, and then we're going to see where we land in terms of some of the other initiatives that are happening within CMS. Reporting will be done on Medicare attributed lives. Next slide. So what they're trying to do is to provide an option for ACOs to report digitally. As you know, if you're in the MSSP program, right now there's the web interface, which is a pretty manual process to get all that data together. Going to the standard MIPS CQMs or ECQMs requires a lot of work. And not to say this isn't a lot of work, but it's sort of an intermediate where you are going to a digital reporting mechanism. You are reporting across all of your providers, but the number of patients that you're reporting on is whittled down quite a bit. Part of what they're doing is they've listened to the ACOs talk about the fact that if they're in rural areas or if they're supporting special programs, what they've seen is some of them feel like it really pulls their score down if they have to report all those patients. Again, intended to reduce barriers to digital measurement, provides the path to align with the Universal Foundation for Adults set of measures. And what CMS is planning on doing is at the end of the year, they'll provide a list of beneficiaries that they think are eligible for the Medicare CQMs within the ACOs. This list will not be perfect. They admit that in the proposed rule. It is their best attempt at finding those patients. So there will be work to be done by the ACO to figure out who their list of beneficiaries truly is and spend the 3 months after the end of the year assimilating all that data and getting it into CMS. So this new Medicare clinical quality measure, what they want to do is they want the benchmarking to work just the same way as the MIPS CQMs and ECQMs. However, there's an issue because right now we don't have historical benchmarks for these. So they're planning on using the MIPS benchmarks for 24 and 25, and then in 26 they will have special historical benchmarks specifically for these Medicare CQMs. And they've noted that the health equity adjustment will still apply to this performance category when they're calculating shared savings.
Great. Thanks, Lauren. So a
Sure.
couple of things to go over and continuing with the Medicare Shared Savings program and the APP reporting that's coming up. One of the major changes they're making is promoting interoperability requirements. As I shared earlier, aligning all these programs together is something that's very important to CMS, and this is one of the steps. So both programs between the MIPS promoting interoperability and MSSP will be moved forward as one in the final rule, removing MSSP cert requirements beginning in 2024, adding new requirements that all MIPS eligible clinicians, as you can see here, regardless of track, are to support MIPS PI performance category measures. Exclusions for PI will still exist for ACOs, so those that fall below the low volume threshold, those that are voluntary reporting, as well as those that earn a performance score, don't earn a performance score because of reweighting. CMS is encouraging ACOs to report PI on the APM entity level. That is a bit newer. Public reporting requirements. So public reporting for ACOs of the cost and quality categories has been around since the beginning of the 2019 program year. However, in now moving forward, CMS is asking that the PI, or promoting interoperability category score, is also added to that requirement. The other thing that we see here for CMS is also proposing to require ACOs to publicly report the number of MIPS eligible clinicians, QPs, and partial QPs that receive a MIPS performance score of for PI. A partial QP, just for those that don't know, is someone that doesn't fully qualify and hit the numbers needed to be a full QP, and they still have options when it comes to reporting inside and outside their APM entity, including those that are partial QPs and compared to the full QP. So it's someone that hasn't fully engaged in the ACO or APM program. Specialists and ACOs, CMS wants specialists to stay or join ACOs. The messaging was not as clear in the past. In the past, it was very, a lot of talk was around how the measures, the quality reporting, the information, how they were done on cost was really attributed to the primary care roles and those types of clinician types. However, CMS is really trying to figure out how to engage the specialists and the ACOs as they want to move to these people being included by 2030, really everybody. Under current quality reporting requirements, specialists are not as involved. Specialists that report MIPS, including ones that participate in ACOs, have the option to report MVPs, and this is exactly what CMS wants. CMS is considering bonus points for ACOs where their specialists are reporting MVPs. It will be applied after the MIPS scoring is complete, and ACOs will still need to report the normal measure set and data completeness requirements. However, they will get this extra bonus on top. CMS is asking for feedback because they want to encourage specialists to do this. They want to be able to give them scoring and what the scoring may look like, provide bonus points, and also incorporate the health equity adjustment to those specialists reporting MVPs, which will open up that health equity adjustment pretty significantly. Other ACO proposals that are out there: health equity adjustment, the use of number of beneficiaries rather than person years. So I've done an entire presentation. If you want to look on the top of the Health Monix website under webinars, you'll see a presentation under the APP that goes into health equity fully. There's a lot of information around that. But in 2023, health equity was done on a person years. So what that really did was discriminated against patients that were only in the Medicare, Medicaid dual eligibility, or the low income subsidy enrollment for part of the year. The goal for this is to really help ACOs get these people into these programs and incentivize them to be part of these programs so that they can be monitored and helped. And health equity is once again mentioned 1 million times in the proposed rule. Historical data submission to establish 40th percentile. This is really big for those ACOs. This is something that they saw right away as a pretty significant issue. Prior to this proposed rule, the way they got to the 40th percentile was on current year data. So there was never a target for ACOs to go get. Well, now they're going to create a target. So historical data to establish the 40th percentile is going to be calculated using a 3-year performance period. So for 2024, they're saying that quality scores from 20, 21, and 22 will be added up, divided by 3, and will get us the 40th percentile for the quality scores, giving ACOs that target to hit. They're also saying that they will make that target available in December prior to the year starting. This is a very big win for the APP and ACO reporting. All right, so I'm going to fly through a couple things on improvement activities. Really, I put these in the slide deck so that you can go through them at your own pace later. But there are 5 new improvement activities that are on here. There is one practice-wide quality improvement, MIPS value pathways, that I will go into a little bit more detail when we get down to the MVPs. But you can see just from this, they're really trying to move things for behavioral mental health as well as MIPS value pathways to get people more engaged in those categories. They're planning on removing 3 of these measures. Reasons are different for each, but they feel most of the time when they remove IA measures, it's due to the fact that they aren't getting the results that they expect from them, or that the plan for what they're doing is not appropriate in today's clinical atmosphere. So moving into promoting interoperability, and I am going to pop this over to Lauren for the first slide or 2 of the PI.
Do you want to move to the next slide?
I got there. It wasn't clicking, sorry.
So when we look at the actual PI measures, again, I'm not going to go through all the nitty gritty here. Just want to point out that for the most part, the measures are staying pretty consistent. I think the changes in PI are more from the perspective of the rules about reporting. Next slide, Mike. So PI will continue to be automatically reweighted for clinical social worker, clinician type only. But so this is a change, like I said, from a regulatory perspective. There is no automatic reweighting for many types of clinicians that had gotten basically a pass on PI in the past. So take note if you're in one of these categories, because all of a sudden it does pertain to you. And one big change that they're making is moving from 90 days to 180 days. So again, a shift from a regulatory perspective, more work to keep track of your performance. And you have to get started now. You will have to get started, assuming this goes through, by July 1st next year, rather than a lot of people I know will wait until the last quarter currently to get it done. And then they're making a change to the PDMP measure. In terms of the cost category, we do see some changes here. There are 5 new cost measures being introduced. These measures have been through a pretty significant development and testing period over the last couple of years. CMS's intent is to cover every clinician with some sort of cost measure. So these are 5 areas that they felt were significant to develop measures. 3 of them are chronic conditions. So depression, heart failure, and low back pain are chronic conditions where basically you're tracking the patient throughout the entire year in terms of their treatment and care. The ED, the emergency medicine measure, is a new type of measure based on location. We don't have any measures so far in the prior 25 that were specifically based on location. So this is a new approach. I'll talk a little bit more about this on the next slide. And then psychoses and related conditions. This is an acute care episode where if a patient goes into an inpatient setting, they will be tracked against this cost measure. CMS did remove or does propose removing the simple pneumonia measure. That is a measure that is in the cost category, was in for 2022, and they actually excluded it from scoring for 22 as well. So when we look at the emergency medicine measure, there are a lot of things about this measure that are similar to other measures, such as the way we look at attributing the measure, the way we look at figuring out all of the costs to attribute to the measure, the way we do risk scoring, and then calculating a score. However, like I said before, this is the first measure centered around a setting of care rather than specific conditions or procedures. So if we have a patient that is in the emergency department, they will get attributed to the provider that is doing the trigger code. And there's a whole list of trigger codes that are in a fancy spreadsheet that I'm happy to share with you that show how it gets it, when it gets attributed. And then we look at the provider that is the attributed provider, and we look at all of the costs that are related to that for the next 14 days. Now, when we say costs that are related, what we do is we look at things that we feel could be related to the ED trigger, and we include those, and we look at other things that we feel are not associated. For example, if you were planning to have a hip replacement the next week anyways, that would not be part of the cost for this. But if you end up, as a result of your ED visit, if you end up in the hospital, that would be included. And this shows, so like I said, they tested this measure. They ran it against all of the claims. Cost measures are all claims-based, based on your Medicare claims. And they ran this measure against all of the claims for 21, I think. And you can see here that the cost really varies quite a bit. CMS is viewing this as the fact that there is opportunity for improvement, in that so many of the episodes vary so much in cost. Mike will talk a little bit in a bit, but we understand that this is pretty black box to most providers. You can't see how these are being calculated. You really, if you're a physician that's working in the emergency medicine area, you don't know if you're in the 10th percentile or the 90th percentile. And you don't know that until the following year. So what we're trying to do is provide providers with a little bit more transparency so you can look at this data and figure out, you know, where do you think you're going to be. CMS is also including an improvement score. We hesitate to even bring it up. It's 1 point based on looking at your category score year over year. You can get an additional point. Not sure this is terribly significant, but it is part of the regulation, so we thought we'd mention it.
Lauren just wanted to put the graphic up there. So that's why we had that on there. So MIPS value pathways we're going to head into, and we'll go there. Thank you for all of the questions that are coming in. Obviously, I do think we're not going to have the opportunity to get to all of them, but once again, ask your questions away and we'll be happy to get back to you as soon as we can. So with MIPS value pathways in the framework, what's next? MIPS value pathways started this year here at HealthMonics. We already have a number of groups and clinicians that are reporting on the MVPs and tracking them, at least right now, and plan on reporting them during the submission season. You can report as individuals, single specialty groups, multi-specialty groups. There's also something called subgroups that I do go into a much greater detail. And once again, another webinar that I have put on MVPs and what you need to know that you could see at the top of the HealthMonics website and download that webinar for your viewing. as well as APM entities can report MVPs, which I shared a little bit ago. The whole idea of MVPs is to have a foundation of the promoting interoperability, as well as population health measures, enhanced performance feedback, and patient-reported outcomes. Those are in each MVP, and then individually, each MVP has their own cost, quality, and improvement activities associated with them. They're trying to combine similar provider clinician types to be reporting on things that make it easier to compare them to each other, rather than having different specialties reporting on a lot of primary care measures. So there are 5 new MVPs in 2024 that are being proposed, focusing on women's health MVP. It's going to have 19 quality measures, as well as include cost measures for the MSPB and TPCC. I won't go through all of them, but I do want to point out one that's really neat for us here at HealthMonix is that the Quality Care and Mental Health and Substance Abuse MVP disorders MVP has 15 quality measures and includes our own MBHR measures that we partner with the American Psychological Association to create. So that is a pretty big deal to have an MVP and things to show you that we are very engaged in the MVP process and basically have our own MVP there. Each one of these do have cost measures and some of the new cost measures. So one of the important things to know is you really can't have an MVP without a cost measure. So if your specialty doesn't have a cost measure currently, they really can't have an MVP at this point in time. Some of the revisions to the MVPs, some things that you'll see consistent, or some of the same measures are being added across each of the MVPs. I think CMS heard at least me screaming loud and clear that the measures currently in MVPs for reporting is very poor, and it was a real hard chance to get do well with scoring through the MVPs. So they listened to that and they definitely added a bunch of measures, as well as improvement activities and a couple of cost measures. As you can see, this is page 1 of that. And then page 2 down here, you could see, and we're going to go into this a little bit more, but on the bottom, the value in primary care MVP is combining 2 of the previous MVPs, the promoting wellness and optimizing chronic disease management MVPs. So here's a little bit more in detail about that. The new MVP is consolidating those 2 measures. The whole idea is to align with, once again, that universal foundation measure set. I think you're going to hear that a lot moving forward. It is a big part of this proposed rule. And I believe, between that and health equity are the 2 main key types that you see very much so throughout the entire rule. The cost measures for this are 5 different ones. So TPCC, diabetes, depression, heart failure, and asthma COPD. Those are 4 of the new ones down the bottom. And then you'll see on the quality measure name side, you see that it's normal measures that you're very used to, like diabetes, advanced care plan, depression, and high blood pressure. But then you could see all the way down to the bottom, there are some new measures, those in the 400s and so forth, down the bottom that you can see. I did want to take one quick look at the IA measure that I mentioned before. One of the 5 IA measures that were created for this year is the practice-wide quality improvement and MVP measure. So the big thing here is that that measure is only able to be reported by people that are doing the MVP. And it really goes into creating an improvement plan on your score. So they want you to really push improving patient outcomes as well as performance in these categories. So really what it is you need to prove that you've trained all your staff, you're promoting transparency to the patients as well as to your staff. So this promoting transparency is for the staff, conducting regular meetings with your staff on updating them on their performance, conducting regular meetings. So promoting transparency to the patient and their family. So, that was been a lot in PI in the past was, giving them access to it, but this is really, showing that we need to educate not only the patient but their family. And then staff-driven integration, having the whole staff going after the same plan and attacking the same ideas of how to move forward. All right, I did want to bring this back up here because the screening for social drivers of health, this is measure number 487 that was added in 2023. In 2024, it has been added to every single MVP. So I think they are sending the message loud and clear. I do believe that this will be a measure that gets added to a bunch of different ways that they're doing quality reporting, including to an APP measure set in the future. The denominator for this measure is 18 and older. So once again, 100 plus eligible encounters. Basically, almost every encounter that's out there is going to have this measure. No exclusions and no exemptions. The numerator criteria for this is patient must have a standardized health-related social needs screening done once per year. So, or documentation that it was done before is acceptable as long as you are reviewing it. Patients are screened for food insecurity, housing instability, transportation needs, utility difficulties, and interpersonal safety. So very similar to the new measure that was added for 2024. For 2024, there's a new measure that basically states if they're positive for one of these, they need to do that measure as well. So they're just building upon this social drivers of health, and I think you'll see that a lot in all of this. All right, so how do you become successful as the program gets harder? So a couple things here, and once again, great time to get your questions in. So reporting methods and why a registry. So why are we doing this here at HealthMonix? We believe a registry gives you the most options out there, the ability to maximize your ROI, whether it is reporting through ECQM, CQMs, or the new Medicare CQMs, using your EHR, or even if you're on paper charts or a certified or decertified EHR that's out there. We have over 200 measures, basically every Medicare measures, whereas a bunch of QCDR measures that we have. We give you better options based on your specialty than your EHR may have. Allows you to pick the measures in which you score best on. So we allow you to track all of the measures that you would like throughout the year and then report on your best measures. Track APP data all year long, being able to look at your performance from the beginning of the year. So if you are a part of an ACO, really giving you the ability from January 1st to understand what's needed and how to report. Reporting all MVPs, so we do have the ability to not only track your traditional MIPS score, but we do have the ability to track all of your MVPs, and you could do both at the same time. That way, when CMS goes to score you, if you report on both, CMS will give you the highest of those two scores. Utilizing the experts, other healthcare IT companies that are out there, what they're giving you is a platform and the ability to report or ability to track. One thing that we really do is we have experts here that understand MIPS, help you navigate and change these obstacles. Combining data is one of the main reasons people do come to HealthMonix to work with us, being able to take data from multiple EHRs, being able to take it from different types of technology and healthcare technology tools for this. And then digging into your gaps of care, so taking a look at your data. Steps that help you succeed, conducting workflow analysis. I think this goes straight back to what we were talking about, that improvement activities and the MVP, really taking a look back and making sure that not only are you performing in these categories, but you really are trying to improve at every step of the way and involving your entire team in that. Look for areas of data collection, documentation, reporting that can be streamlined and automated. Using your technology to your advantage. Don't just depend on manual labor and manual reports. Monitor your practice performance data on selected measures and categories throughout the year. So don't expect measures. I've seen a couple questions here about measure 110 and measure 111 and not having them available in 2023 And a lot of times people are going to be very surprised, especially when they come to us to report in the during the submission season, and they're not able to report the same 6 measures they've been doing for a long time. And to be able to use this data to identify areas for improvement. MIPS Pros here, we are a qualified registry as well as a QCDR. First steps in helping you conquer MIPS, MVPs, APP reporting. We kind of do it all. We do have a US-based support and integration teams right here in Malvern, Pennsylvania, that we are best in class. They're here to help you reduce your burden of quality reporting and provide the highest quality healthcare to your patients is your goal, and our plan is to help you do that. We offer live dashboards and drill down capabilities that help identify gaps in care, improvement activities, score optimization, as well as outliers. How will MIPS Cost Analytics help you? So I've introduced MIPS Cost Analytics a number of times to people throughout the years, but I do believe that this is the most important time to really get a hold of what cost category is. In 2022, preliminary scores that were released about a month ago, a lot of clinicians and practices, hospitals were very surprised that cost was finally counted this year, and their scores were driven down based upon that. So MIPS Cost Analytics helps show estimated cost category score throughout the year. We're providing actionable insights into each cost measures, identifies your anticipated attributed patients and episodes, shares individual patient HCC scores, as well as allowing you to easily identify those patients and providers that have the largest impact. There is a lot in the cost category, as Lauren said, is a black box. And our whole goal is really to enlighten our users to their data and so they understand where they are, what they need to do to improve, as well as how to structure the way they are working currently and change those workflows to improve. This is just, I have 2 screens of examples of what it looks like inside the program. Here, what you see is the measure summary for 2023 showing your entire TIN number of eligible cases, as you can see on the left-hand side, and then those measures that are counting towards your score. One thing that I think is very significant for everybody to kind of get a hand of is that, you may have a very high population for TPCC, but it counts just as much as, for instance, you see the sepsis is only 42 eligible cases. They count the same amount when you're looking at your final score. So you could have a very small population as low as 10 eligible cases for some of the older measures that can impact your score as much as a TPCC would for you. Here's an example if I drill down a little bit into the MSPBC by provider. So what you can take a look here and see is that we really dig into the provider names, what their specialties, how many episodes they have, and then comparing their episodes inside your TIN to those outside your TIN. I know what we talk about a lot in cost and understanding through the years has been cost is not revenue. They are different. Your costs only take up a portion of the revenue for that patient. So if you look at the first one up at the top, you can see the average cost per episode for your TIN is $1,504, but the average cost per episode overall was $20,000. So this provider is only seeing, 10% or less than 10% of that actual patient's revenue. Do pay attention to our upcoming webinars. We do have another webinar next week at the same time at 1 p.m. Eastern. It will be maximizing your MIPS success, so really concentrating on 2023 and what we're doing for that. Feel free to contact me, Mike Lewis, for further questions at the contact information below. I will get back to you as soon as I can. We do have a couple of questions that I want to see if Lauren and I can get to help you out. Lauren, do you see any? Give us a minute, but if Lauren sees any that she wants to grab right away, go for it.
Well, I'm going to start from the bottom. Somebody asked whether we will still have all of our QCDR measures that we have this year, and we are working with all of the registries that own those to borrow them again. Most have said yes. We're actually looking at more measures next year as well. I don't want to commit to anything, but certainly if you have measures that you would like to report through Healthmonics, give us a call, and we will do our best to get those measures into our QCDRs.
Great, thanks. And I know specifically the person who asked that question, we are working on getting many more in your specialty.
Somebody asked how we're getting the data on cost. So we are what's called a qualified entity. We can, after a series of vetting exercises with CMS, they have approved us to get all of the claims data for our providers. And so if you have a patient, what we get is we get all of the claims for all of the patients that you've seen over the last couple of years, and then we can calculate the measures the same way CMS does. So we have all that data, including patient names. We had to go through a pretty hefty process to do that.
Correct. There are a number of questions here about your individual specialties and so forth. We don't have the time to go over each one of those today, but I definitely will get into a little bit more in follow-up webinars as well as blogs about what's happening for individual specialties moving forward.
I just want to remind people that what we're talking about today, I know it's confusing because we're still working on finalizing 2022 scores. We don't have those back from CMS yet. We're in the preview final score phase. We're working on reporting 23 data. This is all proposed for 24. So this is not applicable to this year. There are no changes for this year other than what Mike will talk about next week and what we've already told you about. This is all specifically geared towards what's going to happen for 24. CMS puts this out here in July. They give everybody an opportunity to review and participate in responses and comments. It was about a 2,000-page document, so we quickly read through it, and we will give comments back to CMS along with everyone else. And then what they will do is probably in the beginning of November, publish a final version of this that will be the law for 2024. So this is all proposed. And if you have comments and feedback, you are welcome to contact CMS and give them your thoughts.
Great. And then, there was a question here about exemptions and what is required or not required to report for 2023. So in 2022 and past years, the ability to take the EUC it was available. In 2023. There are options, but the big thing is for cost category, it really doesn't matter. It goes off a claims base and it does not attack the individual who, it really has nothing to do with previous years besides building into trends in your patient population. So it doesn't make a difference if you did not report in previous years, the cost category will be there for you. I will send the entire deck as well as this presentation, a copy of this presentation to everybody by the end of today. You'll have everything out in front of you. We will meet up with more questions later, and we want to wish everybody a great rest of the summer and hope to see you soon back on one of these webinars. Everybody have a great day. Thank you, Lauren.
Thanks, Mike.